Right, welcome back everybody for the sixth session of this conference, which has the exciting title, How Can We Ensure Treatment Options Are Sustainable for All Healthcare Stakeholders? I've been reading the tweets, and I like Catherine C's comment, how can we make, on the previous session, making healthcare affordable and accessible with digital platforms. Did not hear a word on the former, all about big data, pity. Well, let's pick up on that in this session as well, because I think it certainly fits in. I mean, you know the story. I mean, we say, how can we ensure treatment options are sustainable for all healthcare stakeholders? That's a slight euphemism, I think. I mean, by sustainable, we're really meaning, can we ensure that they're going to be affordable for the payers, but also give sufficient incentives for innovators in the future. And you know the background here. I mean, so there's some new products coming on the market, particularly pharma products, which cost hundreds of thousands of euros, even millions of euros per treatment. And I think, you know, when we're talking about stratified or medicine or personalized medicine, and we're talking about often very small numbers of people, we can understand why we end up with a situation where we're paying so much for particular treatments. However, there's another category of drugs that have been coming on the market recently. I mean, the most famous one being Sovaldi for hepatitis C, though of course there are others, and in other areas as well, cystic fibrosis, MS, pulmonary disease, where we're talking about very expensive treatments and actually very large numbers of people being involved. So as a result, Sovaldi, for example, it took 9 months for Sovaldi, the first hepatitis C drug, to actually reach $10 billion worth of sales worldwide, just 9 months before they reached that level. So we have this worry about, yes, affordability in the future because of these big drugs. And yet at the same time, when we actually look at the data on pharmaceutical spending recently, from about 2006, pharmaceutical spending has actually been going up less rapidly than the rest of healthcare spending, and indeed has been falling for several years recently. So we have this slight mismatch between the almost panic about the future because of these incredibly expensive drugs, and the data, at least at the moment, showing a fall, or at least very low growth in health spending on pharmaceuticals. Obviously, part of the reasons for that are to do with the rebates that are given for these very expensive drugs, but also the role of the generics market actually affecting the overall price that we pay for various treatments. So that's the background. What we have in this panel, you'll notice 3 people. Let me start with the person who's not here. We were going to have Vanessa Lopez to speak this morning with us. Unfortunately, she's got a gastro. It's always rather unfortunate when you're speaking at a health conference and you end up with a health ailment, I find. But our best wishes to her. But that means that we don't actually have a patient perspective so much on the panel. So I am hoping for interactive audience participation in order to fill that gap in the discussion. What we do have is certainly a very good representation from academia with Professor Cerniauskas, who is a professor in the Department of Economics in Vilnius. He was a Vice Minister of Health for about 6 years and a Minister of Health for a period of time as well. He works on many different topics, including the pricing of pharmaceuticals. We also have Harry Hemingway, who's a Professor of Clinical Epidemiology in UCL, London. He's the Director of the FAR Institute, which works in particular on health informatics, and your research area is, I understand, especially cardiovascular disease and how we can use electronic health records to pursue that research more effectively. And we have Elke Grooten, who's an industrial pharmacist and worked in the Belgian Medicines Agency before ending up as Director of Public Affairs in Sandoz. And I've promised to treat her as evil and the enemy throughout the the discussions this morning. She's agreed. She doesn't look particularly evil, but I assure you she really is. She's just hiding her forked tail behind her back. That's the introduction. So let's get started. Professor Cerniauskas, would you like to introduce this issue from your point of view?
Yes, thank you. I would like to bit elaborate around the Vilnius Declaration. We are talking about those main three ideas. A first session showed that audience bit skeptical about results. Yeah, we think that something done, but not much. But that's exactly probably reason why we are here, because clearly issues are important and we should continue to go on and be elaborated more. But in any case, our topic about sustainability for all stakeholders. So if to consider that stakeholders are a part of patients, medical professionals, are also industry and governments, and if to be sustainable in long run means that it should be beneficiary for all of them, and if to assume that interest of patients, of course, is good health, and interest of professionals, maybe budgets, maybe other issues, prestige whatsoever, and interest of governments, it's economic growth and unemployment, reduction of unemployment, increase of taxes, whatsoever. So is it possible really to try, according to this definition, to model somehow the question and according to those three issues that had been underlined in Vilnius Declaration. First was to increase investment in health promotion and disease prevention. And again, to be a bit provocative, it's quite clear that almost all public health people, and probably quite many of us are from this type of profession, do believe that investment in public health is super efficient per se. But on the other hand, when you're looking to statistics, we see that share of public health in total health expenditures is not growing. So it's a bit unclear. Either we are more clever than others, decision-making, or something is not exactly right. And probably both are correct, because there are efficient interventions, there are not. And really, it's not just about convincing others that health is about investment. Probably this we had already achieved, but now in almost all documents, at least with big influence of medical profession, you see this. But if we say that it's investment, we say other things. Not all investment, even in those roads or machinery or whatever, are for good, yeah? You may have waste in investment as well. That means the same applies to health, the same applies to public health. So this is, I think, important, and under this assumption, probably yes. If we are clever, if we are not just proposing projects, but we're making assessment, and we are able to convince all those audiences that it's not just something interesting or whatsoever, then probably you may say that it's good to have investment, and it will contribute to well-being, not just for medical professionals, but for societies as well. Now, second issue about universal access to high-quality health services. That was second point, a main point in Vilnius Declaration. And again, already it was discussion about accessibility to health, and there are restrictions. It's clear that doctors not so happily going to villages and other places. So probably we may talk not about really absolute equality or whatever, but about optimal equality. And maybe some countries had achieved this result, but I believe Lithuania not, because we still have 7 years difference in life expectancy between our municipalities. I'm not talking about social groups, but even regional dimension shows that really a lot to be done, and there is room for improvement. But anyway, it's about services. If we are talking about medical goods, yeah, and our conference somehow is a bit more about medical goods, yeah, maybe because of sponsorship. But anyway, I would like to address once again this differential pricing idea. It's not new, and it was discussed. It's not goes far away. But about the sustainability, from the sustainability point of view, I would say that you probably may find arguments that this idea is correct. Because if we know that we have less advanced countries and more advanced, and about half of Europeans are living in less advanced countries. So if we are selling drugs by same prices, we immediately say that less advanced countries will receive goods like in 20 years when we will become as rich as Germany, Britain, or whoever, whenever. So it may be okay, but another option that we are providing access to patients faster. So patients definitely winning, yeah? If there is opportunity to reduce prices for some groups of countries. Of course, professionals winning because new technologies, gratitude of people and whatsoever. Pharma also winning because bigger turnovers anyway gives bigger profits and so on. It looks like everything fine, even better if you will discount cash flows, yeah, because it's clear that today money, it's much more than tomorrow. National governments of countries that produce drugs also generally winning because more production, more taxes, more growth and whatsoever. Of course, there is a split between ministers of health and ministers of industry, but overall, it looks like countries are winning. Those countries who are not producing those drugs, again, winning because less expenses and more health. And we do believe that more health, more productivity, more growth, more taxes, and whatsoever. So for bureaucracy, European also, it's nice because we know that there are problems, but still to show that under their surveillance, something happened, some new ideas had been promoted. Also, it looks like positive. So that's my ideas. And now a third point about this, from this Vilnius Declaration was to assure that health system reforms are evidence-based and cost-effective. Against like nothing special, we talked many times about it, but session before we had shows that, okay, we have data, not always used. We talked about big data. But being a bit provocative, I would like to give another example. Very simple data, World Health Organization based on mortality. We have those for decades. Example not from EU, but from Europe, let us say Ukraine. A country has experienced 25 years after becoming independent, and most of these years they had mortality higher than in 90s. So if to assume that all people who died because of increased mortalities, type of premature deaths or whatever, figures is quite interesting to indicate close to 2 million deaths. So it's interesting data, very simple, available, but somehow we as community, health community, sometimes even such simple figures not discussing different reasons probably, again maybe political issues. But anyway, so let's consider this not just about this something very fashionable things, but also simple things with certain added value. So thanks.
Very good. Thank you very much, Professor. I mean, you made three main points. First of all, we invest in the wrong areas. I think that's a good summary of your first point in health. Second point is about the access. We talked both about the access in remote areas, but also in particular about this differential pricing issue for medical goods, and then this third issue about how we make sure we have cost-effective health systems. On that second point, on the differential pricing, don't you think we sort of have that already, the way that the rebates work in the system?
Yeah. Yeah, we do have this, but it really goes not in transparent way, and it's about form. Not so important probably which form will be decided to be used, but at least in public debates, I think it's better to use more precise terms. How it will be shaped in reality is a different issue.
I mean, you were in politics. I'm just trying to imagine if you were in politics in, say, a country like France or UK or somewhere, and you had transparent pricing and your population started realizing that you were paying significantly more for pharmaceuticals than other countries. How do you think that would go down politically?
Once we had this discussion with ministerial fora, and of course those big countries, a part of Belgium, rejected this idea. Probably arguments were exactly the same. We were scared about political reaction or population. But that doesn't mean that we should not discuss this issue openly. How it will be wrapped in the future is a different issue.
Very good. Let's move on. Elke, you, as I said, are the representative of Pure Evil, being from a pharmaceutical company. You know the story here. We're talking about hundreds of thousands, maybe millions per treatment, which means that we're talking in some cases for new treatments, literally billions of euros of return to the people who have the patent on these drugs. Often, obviously, the drugs are based on publicly funded research, which then the evil pharmaceutical companies manage to add a bit of value and privatize by putting a patent on it. It's not defensible, is it? I mean, are you a force for good or a force for evil?
So, thank you for this very nice summary of everything.
Welcome. Welcome.
So, to be very honest, Mark, I don't consider myself being evil, nor the industry I'm working for. I work for this company, for Sandoz, since 2002, and actually I'm very proud and passionate about the fact that I work for a company that delivers so many good things for patients. Of course, there is a discussion about making sure, as the title of the session says, that this is actually working for all different stakeholders in the system, but I'm convinced that we can make it work, actually.
Well, you, I know, have been working particularly on generics and biosimilars. Mm-hmm. Is that right? I mean, I suppose that is the counter-argument to what I've been saying about you being evil, because there is this, I suppose, life cycle of a product or life cycle of treatments where prices do come down very rapidly. Yeah. On the other hand, aren't we very slow in adopting generics and biosimilars in Europe?
So maybe it's a good moment to go through my slides, because I hope that my slides will bring answers to all your questions and also the questions to the audience. So if we can have the slides up. So maybe let me start by saying that I'm here to represent EGA, so the European Generic and Biosimilar Medicines Industry. These statements that I make here as a kind of introduction for our panel discussion is not a single company view, but is a view of our industry sector. And for us, it's very important to be a partner in this debate. As Adrian mentioned yesterday, our industry nowadays represent 55% of the medicines that are delivered to patients in Europe. And all projections show that by 2020, actually 75% of the medicines used by patients in Europe will be actually generic and biosimilar medicines. So therefore, for us, it's very important to be part of this debate. This is a slide that summarizes 3 important factors that we all know in this audience will have a huge influence on the cost of healthcare. And in my personal opinion, these are not negative things. I think that, for example, demographic progress like aging population, I actually think that this is a very good thing. By 2025, we will be with 1 billion more. 500 million of people will be over, plus an additional 500 million of people will be over 50. But if we get this right and we work together with the different stakeholders in the system, and we do this in a sustainable way for all, these are actually very positive evolutions. Adrian presented the mission of the generic and biosimilar industry. I don't have to repeat this, But what is important is what we see in Europe since the economic crisis. More than half of the member states have basically reduced their healthcare budgets. And this is worrying because, as I presented, we are confronted with some trends that can actually be very positive. Now, from our point of view, generic and biosimilar industry, it is important that policymakers and different stakeholders actually see the uptake of generic and biosimilar medicines as a good solution. Adrian mentioned yesterday that there is enough literature that basically proves that in disease areas like hypertension, diabetes, and so on, generic medicines have increased the access overall in Europe with 100%. And at the same time, in these disease areas, the cost of medicinal treatments have gone down with 60%. So this is tremendously important. Now, biological treatments, biopharmaceutical industry has brought biologicals on the market also for more complex disease areas that are mentioned here, which are basically causing disabilities, but also life-threatening situations like cancer, like arthritis. And it is our aim and our mission also to bring competition by generic and biosimilar medicines in these disease areas. This is actually a very important slide. If you look at this slide, you see in the corner actually the expenditure on medicines in 2008. When you look at 2008, in the top 10 of expenditure, and we see the same picture in all European countries, you see products like atorvastatin, you see clopidogrel, you also see some antidepressants like citalopram and so on, where basically through the competition of generic medicines, we have managed to create this financial headroom that is so important to have this sustainability in healthcare system. If we now look at the top 10 expenditure in the different countries for 2015, we actually see in all the countries that in this top 10, we have 7 to 8 biological or value-added medicines. So therefore, it's extremely important that our industry is also able to create this competition and therefore also this increased access and sustainability of healthcare in this area. And this is not the case, especially not in the disease areas that I mentioned, the more complex disease areas. This is the example of arthritis. We see in Europe that actually the access to biological treatment, which is actually a best treatment for patients, differs from country to country. And even in countries like in France, only around 70% of the patients have access to these biological treatments. And as I mentioned, this is the role of generic and biosimilar medicines with regard to sustainability. Bringing it back to healthcare in general, because we have discussed also yesterday a lot on this is not only about medicines. As a company and as a sector, we are also extremely engaged in delivering patient-centric services that improve overall patient treatments. These are some examples from the company I work for, where we invest, apart from investing in new generic and biosimilar medicines, we also invest in training, in systems where we can basically improve the overall treatments of the patients. So in conclusion, I would like to highlight the importance of our industry in creating this balance, as you mentioned, making sure that the medicinal treatments continue to be affordable. Strong partnership and dialogue is extremely important. It's not only about looking what is best from one stakeholders. We have to talk together. We see in Europe a lot of these multi-stakeholder initiatives which we actually encourage. And as EGA, we want to be part of these initiatives. Generic and biosimilar medicines, it's very important that policymakers in the different member states put in place policies that basically focus on the uptake of the medicines and not only looking at, for example, mandatory price decreases, because also in the presentations yesterday, you have seen that it's the uptake and the competition that brings the sustainability, actually. And our industry looks at ensuring a maximum number of patients. You were referring to some very important and promising innovative medicines. More and more, these innovative medicines focus on a small group of the population. Our role, and it's not an or story, for me it's an and story, it's a balanced story. Our part of the responsibility as generic and biosimilar medicines is to make sure that the maximum number of patients receive the best health outcomes. And in a conclusion, but I think it's not a discussion point with this audience, health has to be seen as a good investment, and we have to move from these short-term measurements in order to control budgets towards a more sustainable and a more efficient policy to guarantee healthcare also in the future.
Wonderful. Thank you very much, Elke. I mean, I completely agree, and I'm sure that everybody else agrees with your last statement. I mean, this idea that generics can play an important role in keeping healthcare costs down, which allows us to invest in health in the future. So why is it that we see such huge differences in take-up of generics across Europe? Why is it that some countries manage to do so much better than others?
So, so there has been a lot of studies around it, and I think there are a few issues that are important. I mentioned the fact that member states have to focus on uptake. So it's not about price. Our role is to create this competition. So uptake is extremely important. It's extremely important that healthcare professionals, prescribers, pharmacists, and also patients, first of all, understand generic and biosimilar medicines. Education is crucial, that we see in the countries where it works, and also that that there is a stimulus for all stakeholders to use generic and biosimilar medicines.
Very good. I'm sure we'll come back to those issues again. Let me move on to you, Harry, because of course one of the reasons why we often hear that new drugs are so expensive is the huge costs of producing them. I mean, you hear numbers quoted of, to bring a complex molecule to market, $1.8 billion, things like this. What can we do to actually bring the price of innovation down? I mean, is there anything that is this where your research fits in?
So, to answer that question with one word, and it's a four-letter word, and I apologize because it spans the previous session and this session, it's data. So I would like to ask the audience a question. How much does it currently cost a research funder to recruit a patient into a study, any kind of study? It could be a trial, could be experimental medicine.
$6,000.
Wait till I finish the question. To assess them, to follow them up for benefits and harms, for clinical outcomes over the long term. So we have a value here. Can I go to my first slide? Is that possible? Because I'm going to give you the precise answer, and the answer that motivates me and gets me up in the morning. That is the answer. So we recruit, assess, follow up millions of patients through the electronic health records. And the cost to the research funder for collecting those, that is my first slide.
That's your first slide?
Yeah, it's zero.
Oh, I miss it.
It's zero. That's the point, is that it costs zero. So that, if you hold that figure in your mind, that is one of the ways that we can tackle what is sometimes called Eroom's law. Do you all know about Eroom's law? Mm. So you know about Moore's law. So transistors in the our computing power is exponentially improving. If you plot over the same time axis in billions of dollars per new pharmaceutical licensed, you see an inverse of that. Eroom is a palindrome of Moore's law. So how are we going to address that? My central thesis is that we need to unlock the data that we have. And I will say more about that if you want me to now.
Go on.
Okay, so I'm going to give you a research perspective. I work in a university, I do research. I'm a director of a research institute. And that, more specifically, is where I come from. That is, in fact, my building in central London. And in the time it takes me to boil a kettle, I'm in the Far Institute, I'll tell you more about that in a second. In the time it takes me to boil a kettle, my colleagues can walk round the corner and discuss with basic biologists their research. They can walk a little bit further and talk to mathematicians and computer scientists and discuss their research, and hop on the train to the genome campus at the Sanger Institute. So it's highly interdisciplinary research that's going to give us sustainable value here. And just so you wonder who those people are. So we are in a new era. We've had a quarter of a century of evidence-based medicine, and no less than the President of the US is inviting us to think of a new era of data-based and more precise medicine. We've heard eloquently in the previous section what those data might be, and it really is the digital trace. It's everything, and it is global. Our 7.3 billion citizens on this planet contribute a rapidly growing digital trace. I won't go into that, but it spans the molecular to the particles in the air we breathe. And that is a fundamental insight, that whether you're interested in public health or whether you're interested in discovering new drug targets, to some extent you may be interested in common underlying data. And I do think that Europe could weave the richest data tapestry in the world. And the reason for that is that we have fantastic, believe it or not, fantastic healthcare systems in many places throughout Europe, with growing opportunities of record linkage, the way we weave this tapestry together. But value is not just about the data. It's about the tools to get access to the data, and crucially about people. One of the most remarkable European institutions from a research perspective is the European Bioinformatics Institute. There are 10 million hits per day on their website. You pretty much can't do biology or genomics without it. Where is the EBI of big data health? It does not exist. And I think within countries, I think we need to attend to that. And between countries, I think we need to attend to that. And guess what? That's one of the rationales for the Far Institute. People. In order to bring affordable medicines through, I think we need to have a whole different culture about the professionals that we teach and train and the careers that they have. We need a massive increase in people who understand how to get value from data. We need hybrid individuals. Doctors who code. Right now we select medical students precisely on the fact in England that they play rugby and they've passed exams. We don't know whether they're any good at maths. That's got to change. And we need a new relationship with our patients and public, without any doubt, as we increasingly sense ourselves, as we engage with our online medical record, as our school children are scientists whilst at school through analysing publicly available data. And of course, most important of all is how we build public trust and negotiate the balance, the proportionate governance between the rights to privacy and the public benefit and the private benefit of good use of data. So if you put data at the centre, what can you do? The fundamental idea is that you can do everything. It's not that, okay, let's focus on mHealth here, let's focus on learning healthcare systems, let's focus on drug discovery, because increasingly the invitation is you can do all of these with greater facility. And as I've said, the platforms and the people that join that together need much greater attention. What's been the situation across the world is that people who do one aspect of that tend not to do another aspect of that. It's been highly balkanized. And that, in a sense, is the rationale for the Far Institute. So what the UK has done is to say, let's establish a national research institute and de-balkanize this field, addressing big questions with big data to improve health. Who was William Farr? There's one of his visualizations. He gave us the International Classification of Diseases with European colleagues. He would recognize the ICD, because we still have that. He would be, I think, very surprised to see health service transformation through whole genome sequencing underway in the UK, and an example of how big data can reside in one individual. But the global reality, of course, is not currently one of data-based medicine. The global reality, and here from the Institute of Medicine, is one of, and this is an American body saying, you know, missed opportunities, waste and harm as we go from science through evidence to care and patient experience. We want to drive better outcomes at a given cost, but a fundamental question for our European colleagues is better than what? It is not acceptable to bobble along at the bottom and say, care and outcomes are improving in my country. I don't think that that's a 21st century valid statement. What matters is comparing across systems, and we've had remarkably little use of big record data to compare outcomes and care across systems. So here, the one piece of data I'm going to show you, in 500,000 people with a heart attack, at 30 days, the death rate is much higher in the UK compared with Sweden. So why, I am British, why am I proud to show you that slide? I'm proud because we know it. And if you don't know it, you can't do anything about it. So there were 10,000 excess deaths here, and I think the question for all of us is, what about your country? So, if this is of interest to you, here's a shameless plug. Please do come to the FAR Institute's first international conference. It's at St Andrews in Scotland, so if you like big data, whiskey, or golf, or any combination of those three, come and join us. Thank you.
Wonderful. Thanks, Harry. That was really fascinating, really good stuff. Now, look, we've had quite a lot of speaking from the platform, so let me turn to the audience. And in particular, maybe first look at pharma. I mean, because the blurb for this session was a lot about whether we can make new innovations affordable or not. Yes, sir, do you want to?
Let me make a comment on differential pricing and whether confidential pricing agreement is a good solution. Yes, it's a good solution, but only it's a second best solution, because the first would be to convince higher income countries not to reference lower income countries, and incomes without special situation to reference countries with special situations like Greece today or countries in public health crisis. So this is the first best solution. And then confidential pricing agreement works only if not all countries use it, because at the end of the day, for example, UK may get better price reduction just because of the importance of NICE decisions in many other countries. So it's a second best solution only if it's used selectively.
So let me interrupt you. I mean, so how should the UK price?
Well, the point is that it's a correction for differential pricing, but at the end of the day, everyone uses confidential price discounts. Who will get the higher price reduction? The larger markets, the countries with huge actually sales or influence on many other countries. So theoretically, in this case, the confidential price reduction can be even larger in large Western European markets than in Eastern European markets in small countries. This is one of the problems with confidential price reduction. And let me just make another comment, which is about the neutrality of the European Commission on this issue. I think so far I haven't seen any research that was sponsored by the European Commission in which the research fund is allocated to those countries who suffer from this. Actually, there are many research in this field, but usually the winners of external price referencing do the research. And I apologize from the industry. The industry does the same. They give funds to Western European research centers to do research in this field. And for them, it's a nice study. But actually for us, actually it's about our patients and our access. So I encourage everyone to think about inequity in research, and also about the neutrality if the European Commission supports the establishment of pricing databases. That's not a neutral position, because actually that supports external price referencing, and so it doesn't lead us towards differential pricing. So my point is that we need to develop solutions that are better, and then maybe more towards reducing the inequity and the accessibility of patients to medicines. Thank you very much.
Does anybody want to disagree or agree with that viewpoint? No. Because I suppose the logical answer is, in economic terms, it's actually highly efficient to have differential pricing in different countries. I mean, there's no doubt about that. I have to wonder whether it's politically sustainable, though. I mean, I think you're asking an awful lot to ask richer countries to deliberately pay more for their pharmaceuticals, publicly admit that they're paying more. Do you not think? Do you find that a credible scenario?
Actually, I just ask that they should not free ride on discounts that is given to poorer countries to improve the accessibility of patients. So it's just a different interpretation of the same concept. I think we need better principles on external price referencing, and this should be the first step. And then the political attitude of accepting that, in fact, higher income countries can afford to pay more for the same drugs. Otherwise, we do not have inequity. The point is that in Europe, we need to think about reducing the gap between poorer and richer countries and patients. Thank you.
Professor Cerniauskas, do you agree with that viewpoint? What would your, if you were advising the UK Minister of Health, what would you advise him to do in pricing policy?
Yeah, no, again, this discussion is already long-lasting, and clearly it will continue. But what is clear, even from our audience, when we voted for more access, 50 or 55% of us were very much in favor of more access. So that means that it's on agenda. And this type of differential pricing or other things, or maybe bigger substitution of research, because again, it may become a game changer, or investing in big data, as was proposed here. There are different ways to tackle the same issue. So I think Europe is far away from final decision, but we are discussing, and discussion is important. How it will go, we will see, but quite clearly that idea that certain solidarity should be in place, I think it's already accepted. How it will go, we will see.
Okay, we have a comment from the back.
Yeah, thank you very much, Elizabeth Kuiper from FPA. I would like to come back to your point about what member states actually feel about differential pricing, because I think it's interesting in this context, because unfortunately Mr. de Kock from Belgium is no longer here, is that Belgium already for quite some time, from 2010 when they had their presidency of the European Council, is that they worked on a stakeholder initiative on differential pricing. And it's like the professor said, they really wanted to start with the principles in differential pricing, since that's really important, because we all know that in practice it's not yet working. So it's important to start to really work on principles on how it could work in practice. And I think also, a bit speaking on their behalf, but we as FPA have been involved, so in that respect I know what's going on in that group, is that their solution is not to have differential pricing for all kind of products. It's really for those medicines who are high priced and do specific have access problem in certain European member states. Thank you.
Yes, there's a comment from the front.
Yeah, I think one of the challenges, maybe, Mark, is with institutions like yours that are out to teach member states how to save money in healthcare when we're confronted with changes, first of all, demographic changes, improvements in diagnostics, and people being treated better. I think if you look, for instance, and you said it about generic and biosimilar medicines, you say, well, it's all about the savings. Well, actually, it's not all about the savings. And as Professor Korms was pointing out, access to filgrastim, which has increased because of the lower price point, indeed, right, is actually about saving many more lives for chemotherapy or bone marrow transplant treatments. So actually, usage rates go up, and it's the same with generic medicines. If you take biosimilar medicines, for example, you go to most Eastern European countries, very limited access to monoclonal antibody biopharmaceuticals. So that means that biosimilar medicines will introduce those, of course, at a cost. We don't give those away. You have to pay for them. And I think this is a challenge. And if I look at most of this stuff, I mean, certainly maybe for drug development, you'll be able to lower costs. But if I look at the other panel on big data and how it's going to think, this is going to increase the cost of healthcare. It's like with our telephones. 10 years ago, we had a telephone, or sorry, 25 years ago, we had a telephone at home. We could call people and everything. It wasn't that expensive. Today, we have a few cell phones, internet. Our telephone bill is multiples of our former telephone bill, but of course, we do multiple more things with that. And I think this is also where healthcare thinking should be. We should be maximum efficiency, but I don't think we should be maximum savings. Otherwise, we won't be saving any lives.
Yes, please, Elke, yes.
I would like to add something on what Adrian is saying and also what Elizabeth was saying, because Elizabeth made a very important point. We understand the issues and the challenges that payers and authorities have, but it's important that these very controlled, drastic ways of looking at prices of medicines are looking at where the issues really are. We see, for example, in our experience, our expertise is these generic and biosimilar medicines. As I mentioned before, the uptake, the creating competition is what brings access, as Adrian mentions, what brings sustainability. Where sustainability is in danger is where we see, for example, in countries putting in place mandatory price cuts from one day to the other. We often use the example of Spain, where you have nowadays a treatment for your high blood pressure for 25 euro cents a day because of a generic medicine. 25 euro cents a day, it's incredible. What can you buy for this amount of money? Nothing. Now, if we have then these discussions with authorities and with payers on how can we bring this 25 euro cent to 23 or 22, this is at a certain moment, it's a ridiculous discussion. It's an unsustainable discussion. The issue is, like Adrian mentions, the issue is how can we treat more patients for these 25 euro cents? That is the discussion about, not about bringing the prices down to the minimum, because at the end of the day, this is not sustainable.
I have so many things I want to say, but let's from the audience.
Hi, Anders Olausson, President, European Patient Forum. I'd like to turn it to a different perspective in this discussion and address Gediminas and Harry here. We listened to the commissioner who's talked about holistic view. He says that we have to identify all the areas that a chronic disease is affecting in a person's life, more than the health part of it. And also bring all these stakeholders, all these actors, responsibilities together. I'm thinking of, if we have an intervention, say we have two different kinds of intervention for a patient when it comes to he needs an intervention. I say intervention instead of treatment, because treatment can be more than a drug. We have A, it costs $1 million. We have B, costs 25,000. Yeah. But if you take the million, A version, that has a great result on the longer term in other areas. That person can start to work in the future and create much more. And the shorter one has a good intervention shortly, but doesn't have the long-term possibilities and the positive outcome. Is it possible to get hold of the other budgets to be co-payer in the intervention from the beginning? That's how lean production works in the industry. Why can't we make this in the healthcare arena as well? Because if we don't bring all these different budgets together, then we will never have a holistic view on the treatment, and we will never have a true sustainable healthcare system. Because health is not only about healthcare.
Why don't we let you answer that, both of you? Yeah.
I try to reflect. In my presentation, I tried to put the point that, for example, with differential prices, even if maybe not politically viable for ministers of health, but it may be useful for countries, because countries producing and increasing jobs and income and taxes and whatsoever. So I think it corresponds to your idea, but clearly there are so-called side effects, yeah, where not for health, but for other. And if we are talking just to ministers of health, it's difficult. If we are talking to cabinet of ministers, yeah, prime minister involved, minister of finance, minister of social affairs, or whoever who takes care of those disabled, of course there are opportunity. Taxes not fixed, budgets not fixed. So it's of course very difficult in each country, but this type of rearranging budgets, if really medical community has enough clear evidence that it works, it may go correctly in most of countries. And I think most of our countries doing like this. Less or more efficient, but this bargaining is going on. That's why, as a result, health, and with OECD, almost all studies show, and even recent, last month we produced on pharmaceuticals, but we do forecast growth of budgets for health faster than our economy that's growing. So what it means? That people do believe that value added is bigger here. Our products, what created in health, are more important than products in production of roads, military equipment, or even education. So I think health community is doing this. Just our discussion is more about shaping with arguments and more precision to achieve results.
Yes or no?
I would say yes, but it's so sorry. But.
Harry, yeah.
So yes, it's a great question. The answer is yes, clearly. I think the results are to be determined to unfold. So one example would be in, I'm sorry it's in the UK, but it's an interesting example because it was driven by the Chancellor of the Exchequer to establish joined up budgets for health and social care with data at the centre of driving that forward, and that's in Health North, centred around Manchester. And I think it reminds us that health is more than the sum of its biological components and more than the sum of its druggable targets.
And I suppose just to add to that, I would suggest that that is happening, at least in the mental health area. That's precisely the argument that has been effective in getting more money. But
it's not carried out, and I just want to add this. The only one that carries the true story in all this holistic view is the patient, because the patient is the only one who knows the patient journey, and that's why you have to have them align all the time.
And that's a central sort of basis on which to build public trust in linkages and joining up these data. If you ask a 12-year-old, if you tell a 12-year-old that these data and these approaches are wholly siloed in many health systems, that 12-year-old will say, duh, why? It makes no sense.
Very good.
Then I'm 12.
Thank you. I want to comment on this also, because we're talking about how to ensure that treatment options are sustainable. And actually, the patient is also a cost factor in this, because there is evidence, quite a lot of evidence now, that patients, when they are involved in the decision making and really making an informed decision in accordance with their personal goals, they do not go for the most interventionist treatment options available. Now, there was a very interesting study in Denmark recently on orthopedic surgery, which showed that after a shared decision-making process using decision aids, 1 in 4 of the patients opted for surgery, whereas in the control group, 4 out of 10 chose the surgery. Now, that's very well in line with other studies from different interventions and in Cochrane reviews as well. So, in a way, there's quite a lot of saving to be done, also for the patients, because they then don't need to have procedures that they don't want. But you need to invest in other parts, for example, in shared decision-making, dialogue, health professionals training, and good decision aids.
Look, I think that's a great point. I wonder what the panel think about that. I mean, to what extent do you think innovation in health is driven by the suppliers of innovation rather than what the patients actually want? And if so, what can we be doing about that? Does anybody, Harry, I can see you desperate to come in.
Make a comment on that. If you imagine a pendulum from benevolent despotism, the healthcare professionals making all the decisions, shared decision-making here, and then forget the healthcare professional completely. So in Genomics England, a survey in many countries around the world, what do people want to know about their whole genome sequence? And people, in general, different backgrounds in different countries and cultures, want to know everything. They don't want the intermediation of a healthcare professional who says, oh, we're not sure what it means, so maybe you shouldn't have it. Sorry. So I think we're in a very interesting time now, and it relates to comments Mark made earlier about we have a decline in accountants. You didn't actually say whether we should have a decline in other kind of healthcare professionals, but I think it relates to big questions.
Can I maybe
Elke?
a little bit less as an expert, I'm sorry, but what Kajsa says is very important. At the end of last year, there was a roundtable discussion organized by the Flemish Cancer Liga and also the European Cancer Liga around the sustainability of cancer treatment. So the topic of our session, but specifically on cancer. And what was very interesting was we had the different stakeholders also around the table, which in the beginning always causes a little bit of tension because everyone is looking at their own area. But I totally agree with Kajsa says, and maybe even more as a patient than as a representative of the industry. If we make sure that the patient receives the right information and the right education, I'm sure that patients can make, I know that patients can make very, very rational decisions.
Professor, do you want to comment on this?
Yeah, maybe not directly, but the question was like about this technologies that are supply-driven. I think there are no clear answers. Sometimes yes, but again, it's up to those stakeholders to confront those ideas that are just efficient to someone and to assure somehow that as a result we have in the market products, not necessarily with pharmaceuticals, but even those managerial tools that really sustainable in long term. It's a process. Of course, everyone plays for his or her own interests, but as a result, we have interaction, and that's why patients important, and ministers of finance also important, because we also have a clear case where we need to balance their books. So we should respect these people as well, and it goes.
Okay, well, this does relate to the first of the questions that were prepared for you. Can we put up the questions, please? The first one for this session, which is, here it comes. Yeah, we know how to do it. There we go. Can we develop a common definition of valuable innovation, starting from patient needs and societal needs? And based on this, develop common principles for how valuable innovation should be encouraged. Okay, you know what to do. Everybody vote. Love the music. We done? Well, that's certainly the most clear response of this morning, I think, in terms of being, mind you, we're long. Oh, no, that's right. No, it does add up to 100%. For a moment, my maths was was deserting me. I suppose the question, though, is, right, that's great. There's well over half saying that they agree. How do we do it, though? How do we go around finding out what valuable innovation is? What's the process? Does anybody out there have views on how we should be identifying valuable innovation from a patient and societal perspective? Great, thank you.
Well, we are not only the multi-stakeholder group, but we are asked exactly in what we are talking about today, but I didn't want to. But I'm going to do it. Okay. In the Netherlands, they are having the problem that they want to reduce the cost. So now patients are actually getting excluded from certain pharmaceutical or non-pharmaceutical, that's the discussion. So it's more about, is it biochemical to be done, or is it the burden of disease? Because when it's the burden of disease, it has an impact on the economic unit person. So if this person is not getting the treatment, he's actually going to cost a lot more for the society. So now we had to find out how can we make this measure. So we were looking into it, and we are having a paper going up on the DIA in November in Hamburg. So we used HTA plus health impact assessment through the health economics. Plus we were looking into what is then actually the impact on the workforce that is coming in. So when we were putting all those things together, then you're getting close to what you're actually arguing here. And that is going into the higher court right now, because already 3 times the patients were winning the case that they wanted to have this treatment, and not because it was not proven in a double-blind study, but it was about the burden of disease. But now we have to convince this old system what to do, and that's where we are using this information.
Great.
Thank you.
Yep.
I love this question. It's the best question so far at this conference. This paid my whole trip, because this is what I am fighting for so many times, and that is, how can we start discussion? What kind of society do we want to have? What kind of value should be the principle in society? That is what we say. Develop a common definition of valuable innovation. That starting from the patient need and society needs. This is what this conference is doing. This is what we did in Vilnius last year. And I think what we need now is to add the health economist, but we also need to add it, to lift it, to take it to another level. So after, I would say that demanding the Riga roadmap to lift this to the next level so we can have a discussion from a more broader view. We are discussing today very, very small different items that all the society consists of. But we also need to discuss a cross-silos perspective. What kind of society we want to have? How do I want to be seen as a citizen, as a patient, as a person? What is most important? Is it that we are happy and enjoy our life, or that we have a strong army? Or what? How do we balance this, and how can we discuss it? This needs to be added to it. So I love this question. I don't understand the person or the persons who, the ghost one who voted one here.
We won't ask people to say, unless they want to say why they voted one, but comment here.
Can I just make a caution from medical history that value changes over time? Aspirin was stopped in development multiple times by Bayer because it had no value. It was kept on in secret by the researcher who wanted to relieve the pain of his father. We've only discovered very recently how aspirin and beta blockers can save a life year for less than 500 euros. I talked about how docetaxel, a very high-cost drug that offered only a minimal advantage over paclitaxel, was developed. It wasn't very good value, and yet this year it's the game-changing drug for advanced prostate cancer. So I'm very worried. By focusing on value, obviously the idea is to choke off innovation that appears to have no immediate value. But the internet, genome analysis, had no value when it came out. It was blue sky, and only now do we realize how valuable that was.
Yeah, I mean, that's a fascinating point. How would you reconcile the two then? I mean, because there clearly are some areas where as a society we are feeling the lack of innovation. I mean, dementia being a classic example, I mean, where the and for that matter, antimicrobial resistance and new antibiotics, although that's maybe changing. I mean, how do you reconcile the two? There clearly are some areas where we are desperately in need.
I understand the difficulty of it, and I think one point would be that you still have to invest in innovation research that appears to have no great value. So you need two streams, because there are things that have potential for value. For example, we know that academics in Britain in recent past would be given a research fund that they could spend on their own way. Nowadays, that's been taken away. They have to go to their peers and get agreement that their research is worth doing. And there's been a worry that that means that it's all focused on short-term outcomes, things of immediate value, rather than of long-term value. So I'm just arguing for twin streams, that you look at value, yes, but potential value is very hard to understand. I co-steered the Blue Sky Cancer Group with the Centre for Financial Innovation, which had all Britain's medical Nobel Prize winners on it. It was a good thing as a young lecturer. And we looked at what would cancer medicine look like 100 years from now, cancer treatment. Not because we could skip 100 years, but what institutions would be required to deliver that change over 100 years. And I don't want you to throw away that value, the 100-year view, for the 5-year horizon scanning, value-based NICE assessment.
Fascinating stuff. I mean, I wonder whether one of the things that maybe we should be doing is to move towards patient-reported outcome measures as our measure of what we're trying to achieve in health, as a way of institutionalizing what it is we're going to value in health. I wonder if that has any resonance in the audience.
Absolutely, but I disagree about patient-reported outcomes, and what I like to say is more like patient-designed outcome measures, because we really need to look at what patients want, rather than just asking them to report on the measures that we've already defined for them. But what I wanted to say is that, in answer to the previous speaker, was that how many times does innovation really start from going to patients and asking them, what is it that you need? I mean, we know that there are discrepancies between what patients value, what clinicians value, what industry values, and so on. For example, a lot of patients are asking for more research into non-pharmacological treatment options for their conditions. That's not reflected in the research agenda. This is what we mean when we say, look at value from the patient's point of view. And then, of course, we have to take a societal perspective as well. And probably the best way to start discussion on this would be at European level. That's my opinion, but then I'm working for a European NGO.
Great. I think we're reaching the end of this session, so I'd like to ask the panel, maybe in turn, have you any comments on this, or indeed anything else that's gone on during the discussion this morning? So either on the how we get patient-centered innovation or anything else. Who would like to start? Elke.
Maybe with regard to the title of the session, I think one word, all the words are very important, but I think we talk about sustainability for all healthcare stakeholders. I mentioned it before, but I want to stress again this multi-stakeholder approach, because at the end of the day, if we don't create this sustainability and predictability for the different stakeholders, it will not work. We had last year a very good experience as EGA where we actually asked GfK consultancy to do a study on sustainability with regard to biosimilar medicines. And in the beginning, all the different stakeholders were really looking only on their own benefits. And then in a second phase, they were looking at also the benefit for the other stakeholder. And it was actually possible to come up with some policy recommendations, coherent policy recommendations that can basically fit everyone. So I would say more dialogue, more multi-stakeholder approach.
What were the policy recommendations, just quickly?
So the policy recommendations were mainly around education, very important, education of patients, healthcare professionals, and also policymakers. It's also about rational use, so looking at uptake measures. So yeah, I think these are the two main issues that came out.
Great. Harry?
Just briefly, Europe could be absolutely great at measuring unmet need, the need that patients express when they consult in primary care or in secondary care. And that consequence would be that researchers might then study the conditions, the symptoms, the comorbid conditions, the diseases that patients actually have through the forward-looking through the windscreen, rather than the rear-view mirror that researchers currently do. So heart attack and stroke, thankfully, are rapidly declining in incidence, yet that's where most of the research effort is on in cardiovascular diseases. Peripheral arterial disease, heart failure, becoming much more relatively important, and they attract less research funding. So patient need, it's partly in the clinical records.
Great.
Yeah, I do feel that this discussion, what we had in Vilnius and what we have now, is important, and then just why not to consider that with Vilnius, Riga, maybe Stockholm or Berlin or whatever, yeah, countries, if to talk about Baltic Sea or others, yeah, will be continuation of this discussion, because really we have to talk, there are questions that's still not clear for us, but we agree that it makes sense to work together, so thank you.
Great, thank you very much to the panel. Let's say thank you in a normal way. Thank you.